Welcome to The Explainer. Today we're looking at a condition that has a history stretching all the way back to ancient Egypt, but is being treated with technology as modern as robotic surgery. It's called a vesicovaginal fistula, and while it can be absolutely devastating for patients, its story is also an incredible testament to medical ingenuity and human resilience.
All right, here's how we're going to break it all down. First, we'll get a handle on what this unwanted connection actually is. Then we'll see how doctors pinpoint the problem. After that, we'll explore the different paths to healing, take a close look at the art of surgical repair, and finally, check out what the future holds for treatment. So first up, let's get right to it. What exactly is a vesicovaginal fistula, and why does it have such a massive impact on a person's life? Okay, so put simply, a VVF is a tunnel that's not supposed to be there, connecting the bladder directly to the vagina. Now, that word epithelialized is super important. It means the tunnel has lined itself with skin-like cells, which basically turns it into a permanent structure. It's not going to heal on its own. And the result? A constant, uncontrollable leak of urine, which you can imagine causes huge physical and emotional challenges. And this quote just hits the nail on the head. The impact goes so much deeper than just a physical problem. It affects every single part of a patient's life, from their mental health to their ability to interact with their community. It can be incredibly isolating. Now, this is where the story gets really interesting, because the cause of VVF tells a tale of two different worlds. In developing nations, the #1 cause is obstetric trauma. We're talking about prolonged, difficult childbirth without adequate medical care. But in industrialized nations, it's overwhelmingly caused by surgical trauma, most often after a hysterectomy. This isn't just a statistic. It's a stark reminder of global healthcare disparities. So you have this hidden connection causing all these problems. How in the world do doctors actually find it? Well, that brings us to the art and science of diagnosis. You know, the whole diagnostic process often starts with one key symptom, this telltale sign of continuous leakage. And when it shows up about a week to 10 days after a surgery, that is a huge red flag for any doctor. It really puts the possibility of a fistula front and center. So one of the first things they might do is this really simple but kind of brilliant procedure called the dye test. They put a mixture of saline and blue dye into the bladder, place a tampon, and wait. If that tampon comes out stained blue, well, there's your proof. You've got a leak. But to really get the full picture, you need more advanced tools. A cystoscopy is like sending a tiny camera into the bladder to see the fistula opening with your own eyes. For more complex cases, a CT scan or an MRI can create this detailed 3D roadmap of the whole area. And that roadmap is absolutely critical for planning a successful repair. Okay, so the problem's been pinpointed. The diagnosis is confirmed. Now for the most important question of all. How do you fix it? Let's look at the different paths to healing. When it comes to treatment, you're basically at a crossroads. For really small fistulas, sometimes a conservative wait-and-see approach can work. You use a catheter to keep the bladder empty for a while, giving the body a chance to heal itself. But for anything larger, or for fistulas that just won't close, surgery is really the only definitive answer. Now, before you jump to a big operation, there are a few minimally invasive tricks to try. Fulguration is basically using a laser to carefully weld the fistula shut. Or you can use special medical glues, either a biologic one or a synthetic one, kind of like a super glue for the body, to just plug up the tunnel. But when those less invasive options aren't enough, you need surgery. And let me tell you, this isn't just a procedure. It's an intricate process of rebuilding the body from the inside out. It's truly an art form. So surgeons have two main routes they can take. The first is transvaginal, going in through the vagina. The big advantages here are less blood loss and a shorter hospital stay, no big incision on the belly. The other route is transabdominal, through the abdomen. This is usually reserved for more complex cases, especially if other repairs need to be done at the same time. So let's take a look at what's happening here. This is the very first step in that transvaginal approach. The surgeon makes this really careful circular cut right around the fistula's opening. This allows them to create these little flaps of tissue that they can gently lift up, giving them access to the tunnel they need to close. Now, this right here is the absolute golden rule of fistula repair, no matter which approach you take. The goal is to close the hole in at least 2 separate layers. And the key is that the stitch lines can't be right on top of each other. And this is crucial. The closure has to be totally tension-free. Any pulling or tightness in a repair is likely to fail. And to make that repair even more secure, especially in tricky cases, surgeons have this amazing technique.
They bring in what you can think of as a living biological patch to reinforce the whole area. And here's one of those patches in action. This is called a Marcius labial fat pad. A small piece of fatty tissue from the labia is carefully tunneled over and stitched on top of the repair site. What does this do? It brings a brand new, fresh blood supply right to the area. And that blood supply is the magic ingredient for strong, healthy healing. This slide does a fantastic job of showing you the difference in perspective. On the left, you see the transvaginal approach. The surgeon is working from below. And on the right, that's the transabdominal view. They've actually opened the bladder to get to the fistula from above. Two different routes to the same destination. And when they do use that abdominal approach, the go-to biological patch is often the omentum. It's this fatty apron that hangs down in the abdomen. Surgeons can mobilize it, bring it down, and place it right between the bladder and the vagina to act as that critical reinforcing layer. Again, it's all about bringing in that healthy blood supply.
All right, so we've seen the problem, the diagnosis, and the incredible arch of the repair itself. So for our final section, let's look at the results. How well does all this actually work, and what new innovations are on the horizon?
Well, just take a look at these numbers. The main takeaway here is pretty clear. Modern surgical repair for VVF is amazingly successful. I mean, whether it's done transvaginally, with an open abdominal surgery, or even with a robot, the success rates are consistently in the high 90s, even up to 100%. That's just incredible. And what's more, newer technologies like robotic surgery are making a real difference for patients. You can see it right here. With a robotic repair, there's about half as much blood loss on average. And look at this. The hospital stay is cut down from over 5.5 days to just about 3. That means patients get to start their recovery at home much, much sooner. So, we've seen how modern medicine can masterfully mend the physical injury. The surgery can rebuild the body. But the journey doesn't stop there. The social and psychological wounds can run just as deep. And that leaves us with one final big question. A successful surgery is one thing, but what comes next in truly healing the whole person?